Hi, this is Roger Green, host of the SurfingNASH Tsunami podcast. Today we are offering 4 conversations from episode 44, our look at screening T2D patients and ways that MASH differs in women versus men and among women based on menopausal status. Plus, from the vault, a conversation from 2023 about different primary care screening strategies for MASH. This conversation starts with me asking Roberta Forlano to describe the demographics of the population in the Northwest London region where the study was done. Roberta comments on the robust diversity of the population, after which Louise Campbell amplifies this point by noting the large number of Arabic and South Asian patients in the study population. She discusses why culturally this might matter and the challenges those populations might present. From there, we associate the p-values associated with different diabetes drug therapies and their impact on MASH and simple diagnostic methods, why patients might refuse to participate in the study before we wrap up our discussion of the paper. Coming out of this session, I understood why Louise had advocated to bring Roberta Forlano and her work onto the podcast. You'll hear some fascinating data you can use about some of our core target populations. It's a lot of information in a fairly short episode, so just sit back, listen, learn, enjoy. When you're done, join the dialogue on our LinkedIn discussion group. So the one thing we didn't do, I think, at the beginning of this conversation that we might have, was to talk a little bit about the neighborhood, the geography from which your sample was derived, and what the audience might want to understand about that patient population and socioeconomics of the area in general that will help them understand put the rest of the results into context.
Roberta Forlano.
Yes, so Northwest London is a very diverse population in terms of ethnic background. We had a very good representation of different ethnic groups, and also it's quite diverse in terms of socioeconomic background because there are less deprived neighborhood compared to more deprived ones, so there was the whole spectrum. And also I was lucky enough to include patients with type 2 diabetes with the whole spectrum of type 2 diabetes. So we had a good representation of those on diet only to manage diabetes, but also on different combination of medications from different oral antidiabetics to insulin or GLP-1 injections. So, it would have been better to have a larger cohort in this sense, but it was still very representative of a true population, of a true general population, and it was true community population because we basically enrolled patients followed up for diabetes by their GPs, so not patients followed up in the hospital. So I went to the community clinics and they were patients from general population, true general population, so unselected.
Louise Campbell.
I think it's actually worthwhile breaking down the ethnicity of this population because it is so good for Imperial and where it's based. It's probably the largest Arabic community out in the UK. So only 32% of the population studied were Caucasian. 12% were Afro-Caribbean. 28% of the population were Arabic. Southeast Asian was 17% and East Asia were 8%. Now, I think when we come to the normal clinical trials, when we're looking at adding the medications, we would subcategorize most of that population as Caucasian, but they react differently and they have differences of ethnicity that influence their NAFLD and also religion in the way that you fast or diet. And when you do their FibroScan at the beginning of Ramadan, it's highly likely to be different at the end, things like that. So there are nuances in this population that are absolutely unique to Northwest London, but it certainly reflects the population, aka we treated the largest population of genotype 4s in the country because it is that population. But it is worth just commenting on the diversity of that population that would be classified as just Caucasian in a clinical trial for any of the medications.
Yes, we were lucky to capture this diverse population. I think this is one of the strengths of the study because many others had a different ethnic representation. So I think it's even more representative of a general population.
So I guess I just had one more question, and then if no one else has it, I'd love to move on to the other paper, which is I was struck by the idea, and these are small sample sizes, but that the p-value for MASLD between patients on oral agents and patients on GLP-1s were neither one quite reached significance, and they were roughly the same. I'm wondering if that's about the small sample size on the GLP-1 group, or if that's a result we would have expected, given that we've learned that GLP-1s are pretty good on controlling activity score over time, but maybe not as effective against fibrosis levels.
If we had a larger sample, it would have been good to do a sub-analysis, a specific sub-analysis for medications, but in this group, the different antidiabetic regimes did not really make any difference, not not only medication, but also diabetes control as HbA1c. It didn't seem to be associated with a greater or a lower risk of fibrosis. This was also a surprise for us as well. But probably among the factors, it was BMI stronger than glycemic control. So probably a larger BMI may reflect a worse metabolic status over the simple glycemic control.
But A1C did have, if I'm reading your table right, A1C did have a table 2. A1C did have a significant p-value.
Yes, but not in the multivariate analysis. When we moved to the multivariate analysis.
That's right, it fell out.
Yes, it fell out. So we were quite surprised. We were expecting HbA1c or glycemic control to be positively associated with fibrosis, but it was not.
Jörn Schattenberg.
Yeah, if I comment, I was going to say that's interesting too. I mean, it's an all-diabetic population, so you end up with very few on the lower side, I think, and that has peculiarities. I think if you move outside of that only type 2 diabetes population and move into screening populations for clinical trials, you'll see some of that. But again, that speaks to the differences of cohorts, because we've actually done an analysis in a clinical trial population where we saw some associations there.
Yeah, that makes sense. Although I was struck when I looked at the multivariate. Donna Cryer said a couple of years ago on this podcast that if she could give every physician one instrument in the world they could use to figure out who had fatty liver or not, it would be a tape measure, and they would do waist circumferences. And at least in this population, when you take a look at the p-values, that lands, doesn't it?
Yes, waist circumference was quite strongly associated with fibrosis, very strongly.
Okay, so before we move on to the literature review on women, Roberta, any closing points you have or any closing points anybody else wants to make?
I just had one observation. Did you observe any difference in COVID outcomes? Because, of course, you started a lot of these patients before. Then we had COVID, the high-risk populations for COVID. Did you see that in any of the more severe fibrosis, or the too small a sample size?
No, we didn't look into that. So, no, I don't have an answer for that.
I have another one, Roberta. Who did not participate? You offered this to patients, and it was voluntary, right, to enroll in this. And, of course, we're getting the ones that are health conscious and open to this. Do you have an idea? Maybe you don't have their data because they didn't consent, but maybe who are we missing?
Yes, exactly. I don't have access to their data, but I talked to them. So, yes, there was a proportion of patients who didn't want to engage with not only with research, but with screening. Didn't want to know about their liver, didn't want to know about their medical condition. This population, probably numbers would have been even higher if we managed to include those people as well.
Is it language barrier? Is it foreign cultures? Is that an idea?
No, I don't think it's foreign culture. I think it's the inclination or their desire to be engaged with medical doctors and to know more about their own health. Many patients were in denial, I think.
Sometimes it's time restraint, right? If they have to stay for another 15 minutes, it's time.
Yeah, I mean, we did manage to work around their schedule. So we even saw them on, if necessary, on out of hours, so just to increase the uptake. But for some patients, I think it was more like they were not interested in doing the screening, and they were not really engaged. They had a history of not attending appointments, so it was in the context of a problem of engagement in general.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded the conversation, or send an email to questions@surfingnash.com. We'll be back next week with more individual interviews. We're still lining these up, but likely topics might include the impact of the Hamas invasion on the Israeli medical system, and or how U.S. payers are looking at the coming MASH prescribing patterns, or maybe something else. We'll announce our subjects and topics early next week. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.